Anterior uveitis. Example of a clinical case presentation would look like this. A 38-year-old male presented to OPD with right eye pain with redness for 5 days, associated with photophobia, excess tears, and reduced vision. On examination, circumcorneal congestion, grade 4 cells, grade 3 flare in the anterior chamber were observed. Inflammation of uveal tissue from iris to pars plicata. It can be of three types. When iris is only inflamed, it is iritis. When iris and pars plicata is inflamed, it is iridocyclitis. When pars plicata is only inflamed, it is anterior cyclitis. Etiology. It can be infectious, non-infectious, and masquerade. Infectious can be bacterial, viral, fungal, parasitic. Non-infectious can be immune-related, toxins, or traumatic. Masquerade is neoplastic or non-neoplastic. Now we will see the symptoms. There can be pain which can be dull, aching, throbbing sensation. It is worsened at night and it's referred along the fifth nerve. Redness can be due to circumcorneal congestion. It occurs as a result of active hyperemia of anterior ciliary vessels. Photophobia and blepharospasm. This is due to the reflex between sensory fibers of fifth nerve and motor fibers of seventh nerve. There can be lacrimation and defective vision. Lacrimation is due to involvement of fifth and seventh nerve. Defective vision may be due to corneal haze, aqueous turbidity, pupillary blockage by exudates, complicated cataract. We saw the symptoms, now we will see the signs. There can be lid edema, circumcorneal congestion, and corneal signs. In corneal signs, there can be corneal edema due to toxic endothelitis and keratic precipitates. Now, the keratic precipitates can be of four types. There will be mutton fat keratic precipitates, small and granular keratic precipitates, fine keratic precipitates, and old keratic precipitates. Mutton fat keratoprecipitates will occur in granulomatous conditions. It is composed of epithelioid cells and macrophages. They are large and thick, greasy and waxy in appearance. Small and granular capes are non-granulomatous conditions. It is composed of lymphocytes. It appears small and dirty white colored. Fine keratic precipitates are stellate, covers the whole corneal epithelium. Endothelial dusting is seen, and it occurs in herpes and CMV retinitis. Old keratic precipitates is a sign of healing. They are pigmented and irregular in shape. They shrink and fade, and they have ground glass appearance. We saw the corneal signs, now we will see anterior chamber signs. There can be aqueous flare, aqueous cells, and hypopyon. Aqueous flare can be of different severity. There can be no aqueous flare or faint, moderate, marked, and intense. And depending on this, we'll give them score of 0, +1, +2, +3, +4. Aqueous cells, there can be less than 1 cell, then it is negative. If it's 1 to 5 cell, it can be negative or positive. And if there is 6 to 15 cells, it is +1, 16 to 25 cells, 25 to 50 cells, and over 50 cells, and graded accordingly. In hypopyon, there can be three types of hypopyon. It can be dense and immobile, which means there is high fibrin. It can be Behcet syndrome, where there is cold hypopyon with minimal fibrin. And there can be hemorrhagic hypopyon, which is seen in herpetic infections and trauma. And there can be change in the depth and shape of anterior chamber. This is due to syncae formation. The depth and shape can be deep and irregular or funnel shaped. Deep and irregular implies posterior synechia, and funnel shaped implies annular synechia. There can be changes in the angle of anterior chamber due to deposition of exudates at the angle of the anterior chamber. Now we will see the iris signs. There can be loss in the normal pattern. It can be edematous or atrophied. Edematous is usually seen in active phase and atrophy in chronic disease. There can be change in the iris color. It will be muddy in the active phase and hyperpigmented or depigmented in the healed phase. There can be iris nodules, posterior syncae, and neovascularization. Iris nodules can be Copace nodules, Basaka's nodule. Copace nodules occur in the pupillary border and Basaka's nodule occur in the stroma. Posterior syncae, segmental, annular, or total. Neovascularization can be seen. Pupillary signs. There can be narrow pupil, irregularly shaped, ectopion pupil, pupillary reactions are absent or sluggish, and occlusio pupil. Lens signs. Pigment dispersal. There can be exudates and complicated cataract can occur. Changes in the vitreous and retina. Exudates and inflammatory cells can be seen. Cystoid macular edema can be seen. Change in the IOP. It can be normal, increased or decreased. Complications of anterior uveitis. It can lead to complicated cataract, cyclitic membrane, retinal complications, secondary glaucoma, choroiditis, band-shaped keratopathy. And it can lead to phthisis bulbi. It can be without shrinkage, with shrinkage, or with disorganization. Investigations. Blood investigation, we will see TLC, DLC, ESR, blood sugar levels, blood uric acid levels, serology for syphilis, toxoplasmosis, histoplasmosis. We will see urine examination, stool examination, radiological examinations like CT, MRI, X-ray, skin tests, biopsies, intraocular fluid samples. Treatment. Treatment is of three types: non-specific, specific, and treatment for complications. In non-specific treatments, we will do local therapy where we will give cycloplegics, which is 1% atropine sulfate. This cycloplegics give comfort and relief, prevents sync, reduces exudates, increase blood supply to uvea, and we will give corticosteroids like dexamethasone and betamethasone. And in systemic therapy, we will give corticosteroids, NSAIDs, immunosuppressive drugs, azithromycin, tetracycline, erythromycin antibiotics. In physical measures, we will advise hot fomentation and wear dark goggles for photosensitivity. The specific treatment depends on the cause. We will give anti-TB regimen for underlying Koch disease, adequate treatment of syphilis and toxoplasmosis. In case of idiopathic, we will give them broad spectrum antibiotics. Treatment of complications. In case of inflammatory glaucoma, we will give 0.5% timolol malate drops plus acetazolamide. Post-inflammatory glaucoma, we will do laser iridectomy or surgical iridectomy. In case of complicated cataract, we will do lens extraction. Cystoid macular edema, we will do intravitreal steroids like triamcinolone. In case of retinal detachment, we will do vitrectomy. In case of phthisis bulbi, we will do enucleation.